I'm going to give you some highlights from the seventh World Symposium on Pulmonary Hypertension with a particular emphasis for my first talk on the diagnosis, classification, and basic evaluation before treatment. And my next talk will be on therapy. So I have some disclosures related to pharma. And I just wanted to highlight that my talk today will be based on two important recent documents. The first one is the 2022 European Guidelines for the Diagnosis and Treatment of Pulmonary Hypertension. These guidelines have been developed by the European Society of Cardiology, the European Respiratory Society, and they have been endorsed by the International Society for Heart and Lung Transplantation, and the ERN Lung you have heard about from Oksana Kulish. So these guidelines are very important, and an important message is that they have been developed by a multidisciplinary team of doctors, but also patients. And this is, I think, a key message from today's conference in Lviv. We have also another document which is more recent, that the proceedings of the 7th World Symposium on Pulmonary Hypertension. And you may know that the 7th World Symposium on Pulmonary Hypertension has been held in Barcelona, and the steering committee or the organizing committee of this symposium was myself, Dr. Gallier, Dr. Rubin, Dr. Simoneau, and Dr. McLaughlin. And we were more than 100 task force members and more than 1,000 attendees at this meeting. And just a brief overview on the World Symposia on Pulmonary Hypertension. It all started in 1960 with the World Health Organization meeting on cor pulmonale. Then there was the first real study of primary pulmonary hypertension at that time in 1973. And since 1998, there is a committee which organizes every 5 years, 5 to 6 years, World Symposium in Evian in France, in Venice in Italy, Dana Point in the United States, Nice in France twice, and Barcelona this year. And I'm going now to focus on the first talk on diagnosis, classification, and modern approaches to the treatment of patients with PAH. And clearly the treatment will be the focus on my second talk. So I'm just going to discuss risk stratification at the end of my first talk in order to support the treatment decision made, which will be developed in my second talk. So what is pulmonary hypertension? Pulmonary hypertension is not a disease. It's a hemodynamic disturbance which is characterized by a mean pulmonary artery pressure above 20 millimeters of mercury. And of course, when you discuss mean pulmonary artery pressure, it means that it is measured by right heart catheterization, and this measure is invasive. Of course, in daily practice, you can estimate the pressure by means of echocardiography, but this echocardiography does not give very detailed measures. It just provides a probability of pulmonary hypertension, and I will discuss that later. Then, once you have identified pulmonary hypertension, you have to define whether it is pre-capillary or post-capillary. And in fact, the pulmonary artery wedge pressure and the pulmonary vascular resistance separates the patients with pre-capillary pulmonary hypertension who have low wedge pressure and a high pulmonary vascular resistance from patients with post-capillary pulmonary hypertension with high wedge pressure and low pulmonary vascular resistance. I'm not going to go into the detail, but there are, of course, subtle differences within the groups. But here, the key message is that pulmonary hypertension has a very robust definition. The pulmonary circulation is a low pressure, high compliance, low resistance circulation, and very small elevations in mean pulmonary artery pressure will lead to a strain on the right heart and thus some symptoms, especially at exercise, with progressive right heart failure and a high risk of death if there is no treatment proposed to these patients. So when you have a pulmonary hypertension, you need to classify the pulmonary hypertension in order to see what kind of mechanisms lead to elevated pulmonary pressure. And what we do usually, we classify the patients into one of 5 groups. And it is very simple here. The 5 groups are here in blue, in light blue. You have pulmonary arterial hypertension, which is a rare cause of precapillary pulmonary hypertension. But in this group of patients, there are treatments available. And even though it is a rare form of the disease, the treatments can be applied, you know, the endothelin receptor antagonists, the PDE5 inhibitors, the prostacyclin derivatives. Then you have the most common cause of pulmonary hypertension, and I know many cardiologists are present in LIV today, and pulmonary hypertension associated with left heart disease is much more common than pulmonary arterial hypertension, and this is a group of post-capillary pulmonary hypertension, meaning that the left heart is failing in those patients, and therefore you need to treat them with optimization of the left heart disease. Then the second most common cause of pulmonary hypertension is pulmonary hypertension associated with chronic lung disease or hypoxia, COPD, chronic obstructive pulmonary disease, interstitial lung disease, etc. And when you have such diseases, usually you can develop precapillary pulmonary hypertension, and these patients should benefit from optimized treatment of the lung disease. Then, and I know that Dr. Kopech is going to discuss chronic thromboembolic pulmonary hypertension, you have the precapillary pulmonary hypertension due to chronic obstruction of the pulmonary arteries, and this is a highly treatable disease by means of surgery, angioplasty, and medical therapy. The group 5, we will not discuss it in detail, but it is when the patients present with conditions which are not part of the first 4th group, and in those patients, the mechanisms of pulmonary hypertension are either unclear or multifactorial. So it's a very simple classification, and as you can see in red, there are some recent changes, but overall, the structure of the classification has not changed. And now I'm going to discuss how do you diagnose pulmonary hypertension. And in fact, in the recent World Symposium on Pulmonary Hypertension proceedings, there was a very simple stepwise approach to pulmonary hypertension diagnosis. So when you look at the diagnostic algorithm goals, the first thing they wanted in their treatment, in their diagnosis algorithm, is to provide a simplified approach, which is stepwise, so step by step, and with some fast track for people with possible rare forms of PAH or CTEPH, which may need urgent care, and in fact, a lot of emphasis on the comorbid conditions like left heart disease and lung disease, which may be evaluated less invasively in order to avoid to multiply the right heart cath with no consequences. And when you need specialized management, there are pulmonary hypertension centers which should be identified in each country for specialized workup. So these are the 5 steps, and I'm going to go through them very fast. So the step 1 is very simple. Initial symptoms of pulmonary hypertension, we just heard of it this morning. It is shortness of breath, and especially shortness of breath at exercise and fatigue. And then over time, you may see signs and symptoms of right heart failure, including lower limb edema. When you examine the patient, they have an accentuated second heart noise, they have tricuspid regurgitant murmur, and they may have signs of right heart failure. So all these are seen in the clinic. The medical history is very important in order to see whether the patients have a risk factor for pulmonary hypertension, and the symptoms are non-specific, but they are characterized by shortness of breath and development of right heart failure. After that, you have very simple non-invasive tools, and the non-invasive tools like chest X-ray, ECG, basic laboratory testing, including BNP, oxygen saturation, will allow you to see that the right heart is enlarged on the chest X-ray, that there might be some enlargement of the pulmonary arteries. The ECG will show you right axis deviation. The lab test may show you elevated biomarkers like BNP. Oxygen saturation can be low. And in fact, an important message from the proceedings, without severe shortness of breath, a normal ECG, a low NT-proBNP, and normal gas exchange are indicative of a low probability for pulmonary hypertension. So that's very important to emphasize. But if the probability is not low, you will move to the next step, which is echocardiography and airway and lung assessment. So echocardiography is very simple. You measure all the parameters of the right heart strain, and you will see whether the tricuspid regurgitant jet velocity is above a certain threshold, 2.8 or 3.4 meter per second, indicating probability, high probability or intermediate probability of pulmonary hypertension. Echo will also show you the left heart function, the signs of heart failure with preserved ejection fraction, and possible valvular diseases. Then you will have the airway and lung assessment with blood gases, pulmonary function test with DLCO, imaging of the chest, a CT scan or chest X-ray with a preference for CT scan. And usually when you have pulmonary hypertension and severely low oxygen in the bloodstream, it indicates that there is possible parenchymal lung disease or heart shunts or pulmonary veno-occlusive disease. So these are for cardiologists. In the guidelines we published 2 years ago, we put a lot of little cartoons which indicate what could be the possible signs of pulmonary hypertension, which will guide you to decide whether or not you will perform a right heart catheterization if the probability of pulmonary hypertension is high enough, and if the pulmonary hypertension diagnosis will influence your future management. The step 4, when there is a probability of pulmonary hypertension, it is to exclude first or propose first the diagnosis of chronic thromboembolic pulmonary hypertension, because this is a different form of pulmonary hypertension which is treatable by surgery, angioplasty, and or medical therapies. And then you will also perform a series of tests, including serologies to diagnose autoimmune disease or HIV infection, and walk distance or CPET to analyze exercise limitation. And if you have access to it, but in most countries it's difficult, cardiac MRI, magnetic resonance imaging, which can help you analyze the patient right heart and left heart function. So to make a long story short, the diagnosis and treatment are very simplified in those proceedings. The treatment will be decided after a firm diagnosis of pulmonary hypertension when there is severe comorbid left heart or lung disease. We always prioritize the treatment of the left heart or pulmonary disease before considering specific pulmonary hypertension therapy. But for patients who have a high probability of rare forms of PAH or CTEPH, we need a fast-track referral to follow high-probability patients discovered in previous steps. And what will be done in the patients who have severe pulmonary hypertension or who have high probability of pulmonary hypertension without comorbidities explaining it, we will send the patients to a pulmonary hypertension center. You have a few now in Ukraine. You have also very good centers next to your country, for example, in Poland. And you will perform right heart catheterization in these centers. And the right heart catheterization should be done in good centers with high volume of patients. And they will measure not only the pressure, the cardiac output, the resistance, but also vasoreactivity. And I will discuss that in my next talk. The patients who are vasoreactive to inhaled nitric oxide, they are very good candidates for calcium channel blockers. And you can also try to identify left heart disease, which is very common, as I said, especially in elderly people with comorbidities like obesity, atrial fibrillation, etc. And in those patients, when they present with precapillary pulmonary hypertension, you may decide to perform exercise testing or fluid loading to see whether the wedge pressure increases over time. So this is a simplified diagnostic algorithm. It starts with the symptoms and non-invasive tools, then echocardiography and airway assessment, then exclusion or inclusion of possible CTEPH, and then in PH center, the right heart catheterization, which will be performed only if the results will influence your treatment decision. So in an elderly patient with multiple comorbidities and mild elevation in estimated pulmonary pressure by echo, you may decide not to do the right heart cath. In a younger patient with no comorbidity and signs of severe pulmonary hypertension, you will decide to perform right heart cath because it will influence your management. So in some populations, you may decide to do the test even without symptoms. That is what we call screening. And the screening for pulmonary hypertension is proposed in some patients, such as the patients who have familial pulmonary hypertension. And this is proposed around once a year by means of echocardiography. You can discuss also echocardiography screening of pulmonary hypertension in patients who have a liver condition and who are candidates for liver transplantation. And of course, in patients with systemic sclerosis. So this is the three conditions: familial PH, liver candidates, and sclerosis, systemic sclerosis, where you can consider screening. Then, before closing my first talk, when you have a patient who has group 1 pulmonary arterial hypertension, which is in fact a diagnosis of exclusion, you have understood, you have excluded left heart disease, you have excluded lung disease, you have excluded chronic thromboembolic pulmonary hypertension, and you are with a patient with PAH, you will decide to treat this patient with some drugs which are specific for PAH, and in order to decide whether you will treat the patient very hard or more progressively, you will need to know the risk of death at 1 year. And there are two possible ways to identify future risk of death. This is based on what we call risk calculators. And there is an American developed score, the REVEAL score. And you see that in the REVEAL score, you have very classic parameters like the functional class, the 6-minute walk distance, the BNP, some echocardiographic tests, some pulmonary function tests, some right heart catheterization tests. I'm not going to go through the details, but you have calculators which allow you to determine whether the patient is low risk, intermediate risk, or high risk of death. And of course, when you are low risk, you have more time for intervention. When you are high risk, you need to hit hard and early in terms of treatment. So I'm not going to go through all the tests. You see they discriminate very well the low risk of death, the intermediate risk of death, the high risk of death, based on biomarkers, exercise tests, functional class, blood pressure, heart rate, and renal measures. And you have also the European Society of Cardiology, European Respiratory Society, a baseline model where you have more or less the same tests, which allow to tell you whether the risk of death at 1 year is less than 5%, 5 to 20, or more than 20, which will dictate your future management. Of course, the risk of death is one thing, but the comorbidities are very important. More and more over time, we see patients with comorbidities. And of course, you will not consider pulmonary hypertension as the main driver of symptoms the same way in young people with no comorbidities and severe shortness of breath, and elderly people with multiple comorbidities and chronic shortness of breath. We have baseline risk assessment in the ESC ERS guidelines. We have also follow-up risk assessment. And in fact, the follow-up risk assessment are very important because when you treat a patient, you will have a treatment goal, which is to attain or maintain low risk status. And we always have the big three in the follow-up of patients. It is the functional class, the walk distance, and the biomarker BNP or NT-proBNP. Of course, you may decide on top of that to have some imaging of the right heart in order to see whether the patients present with advanced or less advanced signs of right heart strain. And in highly expert centers, you may perform hemodynamics in non-low risk patients. So this is the end of my first talk. Thank you very much.